are interested in as an organization more broadly is as embedding what we call environmentally sustainable oral health practice. And this is what we want to see, not only in South Africa, but we want to see this commitment to environmental sustainability taking place globally. Now, for those who don't know who I am, my name is Bulela Vava. I am the president of the Public Oral Health Forum. And my job today is much on the easier side. It is to facilitate this beautiful conversation. We have a lovely panel with us this evening. We've got people from Tanzania. East Africa is represented in this webinar tonight. We've got the EU represented by Florian, and we also have our very own homegrown talent, Dr. Moodley, who's also with us this evening. And we hope that this conversation will be one that will spark much debate, but beyond the debate, we hope that it will map out consensus towards a mercury-free world and hopefully mercury-free dentistry across the region and of course across the globe. So mine is to introduce our esteemed panel. We may be separated, of course, by geographies and borders, but I want to say I think we are, though, united in cause. And while we probably will be hearing people who speak a similar language around the issue of environmental sustainability and what we can do as clinicians in dentistry, and what, again, I would hope that healthcare more broadly can do to advance sustainable practices in healthcare. I do believe, though, that there will be moments where we pick a brain or two about contentious issues, about areas that might be not so clearly black and white, but probably a little bit gray. And I hope that by the end of this discussion, we will have transitioned from moving that gray to either a complete black or a complete white. So thank you yet again to those who've joined us this evening for this lovely conversation. We're going to just go into introducing our esteemed panel. For those of you who missed our posters on our LinkedIns, our Facebooks, and also on our X platform, please just bear with me as I introduce our panel today. Today, reflecting on the big topic of beyond mercury in dentistry, envisioning the future of environmentally sustainable oral health care, we have Mr. Florian Schulze, who is the administrative president of the World Alliance for Mercury-Free Dentistry and is the founder of the European Network for Environmental Medicine. Florian is a seasoned environmental health advocate, and he has led many campaigns, in particular pushing for the phasing out of dental amalgam across Europe, earning, of course, himself the prestigious Luxembourg Award for his efforts in the European Union. Florian serves as an expert to the UN Minamata Convention on Mercury, contributing to its working group on dental amalgam. And Florian does have a background in cultural management and environmental medicine and brings over a decade of experience at the intersection of health, policy, and sustainability, advocating for mercury-free, environmentally responsible dentistry. We are then joined by Ms. Dorah Swai from Tanzania, who is with Agenda. There she is, waving her hand for all of us to see. She is with Agenda for Environment and Responsible Development. And she's been with this organization since 2008, contributing to its mission of eliminating health and environmental toxins such as lead paint, dental amalgam, and plastics. She plays a key role in Agenda's policy advocacy work, promoting sound chemicals and waste management practices in Tanzania. Her efforts support Agenda's vision of enabling the public to achieve economic development without compromising health or the environment. This is achieved through collaboration with policymakers, manufacturers, research institutes, and the media, and even civil society, particularly consumer groups. Ms. Swai holds qualifications in chemical and environmental engineering, studied both in Tanzania and at the International Institute for Hydraulic Engineering in the Netherlands. And lastly, I would like to introduce Dr. Rajeshri Moodley. Dr. Moodley is a senior lecturer in the discipline of dentistry at the University of KwaZulu-Natal in KwaZulu-Natal province, and holds a doctoral degree with her research focusing on dental education and occupational health. She began her professional journey as a dental therapist in the Department of Health, where she gained valuable clinical experience before transitioning to academia in 2011. In 2011 as a lecturer in UKZN. In her current role, she teaches undergraduate dental therapy students across several subjects, including operative dentistry, dental materials, cardiology, and dental specialties, and has been nominated for the Distinguished Teacher Award at the university. Beyond teaching, Dr. Moodley is an active researcher, having published in both local and international journals, and presented her work at numerous national and international conferences. She also supervises postgraduate students at the master's and PhD levels, with her research interests spanning dental education, occupational health, and public health. Additionally, she serves as UKZN's designated representative to the International Association for Dental Research South African branch. That was a mouthful, but thank you very much, everybody, for joining us. As we can all tell, we've got quite an exciting lineup of panelists and speakers. How we're going to have this conversation today is we'll start with 15 minutes of presentations from our speakers. Then we will dive and delve into the conversation and the discussion before us. Now, just some rules before we engage. There is a Q&A. Please make use of the Q&A button for those who are in attendance for any questions you would like to ask. Please use the chat function directly either to Kilebukhile or Neo, who are supporting me from the organization to run this webinar. So if you have anything in particular that you want to ask regarding connection or anything like that, please speak directly to them and they will assist. Do use the chat to engage. We will also be looking at the Q&A, especially when we are trying to address some pertinent questions that might be coming from you, our audience. So we will start with you, Florian. Let me just try and share your screen. So we invite Florian to unpack for us the global perspectives around this conversation we are having tonight as we conclude this webinar series. So Florian will run us through the work he and his colleagues have been doing, both at a global and, I guess, European level. Let me try and share your slides, Florian, and then you can please start immediately when you see them up. Where is it? There we go. Please go ahead, Florian.
Thank you, Bulela, for this kind introduction and kind words. Thank you, everybody, for joining this webinar. And I'm really looking forward for the discussion later. May especially welcome Yuka Makino from WHO, who's joining this webinar, and I hope we can also share her views later. So I'm presenting now the World Alliance for Mercury-Free Dentistry. And next slide, please, Bulela. And I would like to explain a bit our work, which is a global effort to phase out mercury in dentistry. And it's an organization with the headquarters in the US, in Washington, led by our president, Charlie Brown. With now we have 6 regional centers worldwide and many partners. And you will see that also Mbulela and Rico Orepido from South Africa are a partner in our efforts, as well as Dorah Swai. And next slide, please. Our work is very much in line with the Minamata Convention on Mercury. It's a UN convention with the goal of reducing mercury emission from all kind of resources, including mercury added products. It entered into force on 16 August 2017 with the ratification of more than 50 countries. At that time, nowadays, it's an agreement which has more than 150 parties worldwide. And there are, next slide, please, several commitments to phase down the use of dental amalgam, as dental amalgam is containing made of 50% mercury and contributes significantly to the mercury emissions or mercury pollution, which is at an alarming level. It was just some figures that it in the atmosphere it has increased to the levels. Mercury levels in the atmosphere are 5 times higher than before the industrialization, and we have more and more information and data about mercury in biota, mercury in fish, and mercury pollution in the oceans. So as of 16 August, this is the ratification time, but the entering into force was 3 months later. As of 16 August 2017, there were only 9 voluntary requirements to phase down the use of dental amalgam, which were which parties should have taken at least 2 of them. It was later recommended to take more of these measures. But of course, some of these measures are like setting national objectives or limiting the waste, were not very efficient to reduce the actual use of mercury. And so after the ratification of the Minamata Convention in the European Union, which adopted a phase out of the use of dental amalgam for children up to 15 years, pregnant and breastfeeding women. And it was proposed at the COP4 in 21 to transfer to make this become a part of the Minamata Convention's regulation. And so it was adopted and into force as of 28 September 2023, that only dental amalgam in encapsulated forms is allowed, and parties were required to take action on this. And of course, they were also required to take action on protecting the children, the most vulnerable population to the exposure of mercury, while already in the body of mothers during pregnancy and breastfeeding. to regulate this use of dental amalgam. And we have additional requirement which was adopted later to draft that countries which have not yet phased out dental amalgam are required to draft a plan or a report based on available information on the phase down of the use of dental amalgam. And this report should be submitted with the submission of the full national report, which the next one is required by the end of this year, by 31 December 2025. So next slide, please. Next slide. So this is what the stage at which we are. I will later talk about briefly about the implementation of these requirements at the moment, but we are now already almost 3 months ahead of the next COP, the COP6, where the parties of the Minamata Conventions are going to decide on phasing out dental amalgam by 2030 or not. This phase out date, you can see in the slide here, includes phasing out in the term of import, export, and manufacturing by the end of the year 2030. And there is an additional requirement, which is written down below, is to take measures to stop the use of dental amalgam in public programs. And at this stage, I may just tell that we have a very good news from the African AMSEN conference. It's the African Conference of the Ministers of the Environment. We just met briefly in Nairobi and adopted a resolution declaring or calling on all parties, on all African parties to the convention, to support these measures, to support immediately to phase out dental amalgam in the public programs, to support a phase out of the trade by 2030, and to implement the measures which were already enforced since 23 to protect the children. And next slide, please. So I'm just, saying this is a picture of the COP5. This is our work. I'm just saying that we, as a World Alliance, will definitely work for this, and we are supporting this target to phase out dental amalgam by 2030 at the next COP. Next slide, please. Next. And just saying how this phase out is already feasible. I'm showing here a graphic you can also find on my on the website of the European Network for Environmental Medicine. It's an overview from countries which have already phased out dental amalgam use in kind of different kind of categories, which regulation, or which countries that have declared not using this, or countries which have stopped the import, and just showing you that this is well feasible is also to highlight that there are countries from all kind of economies that have already phased out amalgam. So it's not like it was for a long time that it was only Sweden or Norway which phased out dental amalgam or banned it in 2008 or 2009. But it's are many countries. It's also 27 countries in the European Union. It's the poorest country of the Europe, from Europe, Moldova, which directly phased out amalgam in 22. We have Indonesia, we have the Philippines, we have many countries in Latin America, and we will hear later also from Tanzania and countries in the Southern African region. Next slide, please. here is just in example, I will just keep this very short. It's a European regulation I was working on. It is the regulation banning dental amalgam by January 2025. And in all the European Union, with only two derogations, which were granted another like a year and a half to implement the phase out. But it is also the decision to stop the ban on the of the export. So an example which where the European Union was not following in all kind of chemicals and chemical products, so that we have now an alignment that with dental amalgam, which is no longer used in the EU, should not be exported. And as soon as the other two countries will join the phase out, it will also no longer be manufactured and no longer be imported. And narrow exemptions will be reviewed by the end of 2029. Next slide, please. For the enforcement of the Children's Amendment, as I said before, and which is already enforced since in September 2023, I would like to highlight and remind you that there, according to our information, Yuko from WHO did a survey asking the parties and WHO countries directly about their progress in the implementation, but we don't have this data. Maybe Yuko can add to this later, but this is the data we have. And according to this, we have from 43 African countries, only 7 countries have already taken action to phase out dental amalgam use for children as required by the amendment at COP4. And we are encouraging parties to do so. And it is also still an issue in South Africa. I will explain this in a later slide. Next slide, please. This is another overview. I want to just to highlight that we have this a tracker of the manufacturers. So a reason why dental amalgam or the transition to mercury-free dentistry is already fully on its way is also that manufacturers have left the business. One milestone was a health risk warning in the US in 2020, when the FDA assessed the studies or the information on potential health risks from dental amalgam, and came to the conclusion that there is a significant risk to not only pregnant and breastfeeding women, but to all women which are planning to become pregnant, so all women in the childbearing age, because the mercury accumulates in the body during the lifetime and can pass the placenta later. And even if the pregnancy starts after the exposure of the mercury, or to mercury. And of course, the US also warned people with neurological diseases to use dental amalgam, and people with kidney diseases. Therefore, the main manufacturers have left the business in 2020. And nowadays we have a shrinking number of manufacturers, with SDI from Australia leading the market. But SDI announced now to also to stop the production in 2028. And we see that there is less accessible, dental amalgam will be less accessible, hopefully more expensive, and that this can contribute to the transition to mercury-free dentistry while we have alternatives available all around the world. Next slide, please. There are several reasons why dental amalgam should be phased out. It is not in the first place. The direct health risks in line with the Minamata Convention and the regulations worldwide we've seen so far. It is due to the mercury release pathways to the environment. And just to give you a picture is that dental amalgam content is, well, dental amalgam consists of 50% of mercury, and the medium amount of mercury is about 0.6 gram. According to the UN, it's even 0.8 grams of mercury, which is far more than for most of or any other products which is still used and not covered by the Minamata Convention's phase-out date. So you can see here from this slide that it's a very complex, the complex release pathways, and you have not only mercury released when dental amalgam is placed or it's removed. You have it in crematoria when people are burned. You have it through burials. You have it already a huge amount of surplus of dental amalgam. The European Union calculated that only about 50% actually ends up in the filling, so the rest is surplus. You can see from a recent study in Thailand that you have all kind of like these cotton balls which are contaminated with mercury after using the material. You have this the tools which are contaminated. You have so many pathways that it is impossible to have like a sustainable, fully sustainable use of this material because mercury is released through so many pathways. Next slide, please. Yeah, I will go through this very quickly. It shows that from the expam samples of countries that alternatives are available, effective, and affordable. That you have mercury-free composite fillings which can last as long as or even longer than amalgam. You have mercury fillings preserve tooth structures that must be removed, but I'm sure you as a dentist know all this, must be removed and replace filling. And you have that you have the proof that if you count in the environmental costs or factor them in, that amalgam is more expensive than composite, for example, and you have it not more accessible in terms of glass ionomer used in atraumatic restorative treatment. And maybe WHO submitted a very interesting report before COP4 or COP5 in 23 in support of this minimally invasive dentistry, which maybe she can talk about later. And she's now posting all this information. Thank you, Yuka. So maybe this comes later. We know that countries are doing these assessments. The European Union did the assessment on the alternatives. Tanzania, this is the regulation here, did the assessment upon the alternatives and came to the conclusion to phase out amalgam. Next slide, please. One statement we all hear very often is that dental associations or departments of health with come up with the argument that composite fillings are taking longer than amalgam fillings. to place. And this is here a statement from our dentist from Sweden, which were never did not work for a long time with amalgam. He compared the use of amalgam to composite, and if you look at this calculation, I believe personally that in many occasions dentists are not calculating, especially in the last factors, that polishing the surface to complete a filling can only take place after 20 hours after it is the amalgam becomes solid. And if this is factored in, it means that a patient needs to come a second time. And this is a much more effort than one can do with a composite, which can be polished right in the same session. So please, the next slide. Now coming to South Africa, I've done some research from the first national report, and I've noticed that South Africa declared to the Minamata Convention that most of the measures have already been undertaken in 21. But there is one something I noticed in the Minamata initial assessment, which said that there were about 2,600, like 2.5 tons of mercury used every year in dentistry, but based on an average of 0.3 grams of mercury per filling. Which is not correct, I believe, if one looks into the capsules and into the dosage as available. And if one takes the average, which is used by the UN, it would be more than 7 tons. So it is a very significant contribution to the mercury pollution in the nation. And we found that there is a national oral health policy and strategy with the goal to phase down the use of dental amalgam by 40% by 2030. So there is something ongoing, and the most recent, and I think this is the last slide before I will conclude. Please, next slide, Bulela. Yes, is the regulation which entered into force in I think it was in February, and then it was a bit of delay. So this is finally entered into force on 1st of April 2025, and it is a regulation which does not cover the requirement from the Minamata Convention to protect the children. It just requires to use dental amalgam in an encapsulated form, which may not exceed 0.58 milliliter, which I was wondering, because it means that many of the second largest capsules are not allowed to be used. And maybe if it does not even specify if it's 0.58 milliliters of mercury or the overall weight of the filling of the capsule, I don't know, but this is very unclear, and it requires the safe waste disposal, and for all persons or organ and that import or use dental amalgam, it requires a phase-out plan, which should include the data on the amount of mercury imported and used, and also the alternatives which should be replace this material. And I'm looking forward to talk about this in the discussion, and probably from the universities we hear more. Next slide, please. Okay, that was just to set the scene. And yes, I hope you enjoyed this presentation, and thank you very much for your attention.
Thank you so much, Florian. You've really set us on an interesting path, and I believe the next speakers will be really hammering it home. Just an interesting fact that I think I should agree with, although I am one person, not necessarily representing a large sample, I have posterior composites in my mouth, and they were placed 12 years ago. And I have had zero sensitivity since. And there's absolutely nothing wrong with my teeth. Just wanted to put that out there. So next we have Miss Swai from Tanzania. Please get ready, Dorah, as I share your presentation. All right, there we go. Please go ahead.
Yeah, good evening, good afternoon, wherever you are. From my side, it is good evening. As I have been introduced, I am Dorah Swai, working with Agenda, an NGO in Dar es Salaam in Tanzania. And I'm happy to participate in this webinar. Next slide, please. Yes, may I introduce, give a short overview of Agenda. Agenda has been established since 1994, and it was really after the Rio de Janeiro conference took place in the World Earth Summit on Sustainable Development. And it is from there the idea came that we should form this NGO. And it was then formed, and it is focusing on promoting responsible development for whoever is doing anything in relation to development. So we work with all corners, all kinds of development activities or development sectors, because our aim is to support environmental sustainability while undertaking our economic development activities. And we collaborate with government, research institutions, professional associations, manufacturers, media. Media is our main area of focus, because it is the one which helps us to elevate our voice to the public. And we work with all the like-minded CSOs in achieving our goal. Next. Yeah, as it was mentioned during the introduction of me, Agenda has been campaigning in Tanzania against many toxics in the environment, the toxics that affect our health. Some of these are the mercury in SGM, lead in paint, mercury in products, plastic pollution, and even mercury in cosmetics, and highly hazardous pesticides. In achieving that, we participate in policy, law, and regulations development, and we implement them at the grassroots, at the national and regional levels, and also we collaborate with other NGOs around the globe during development and during implementation. We are coordinating the IPEN, International Pollutants Elimination Network Hub for the Anglophone Africa, and also the Pesticides Action Network for the Anglophone Africa, which these platforms are made by individual NGOs from around the globe. And with them, we do advocacy materials within the national jurisdiction, even beyond the national jurisdictions. Next, please. Yes, some of the advocacy materials we've developed, I've just put there on the slide to see, because without these materials, we cannot achieve much, because we need facts, we need the information to go to the intended groups. And also, one of our intended group is the policymakers. If we don't take these such materials to them and show that the extent of the problem, then they will not be convinced, or they will not be influenced to work towards what we are advocating for. Next. Yes, here I just showed what has been addressed in Tanzania as regards the Minamata Convention implementation. A lot of is going on in Tanzania regarding even battery recycling, regarding changing of the phasing out of the mercury-containing bulbs, mercury-containing bulbs, thermometers, cosmetics, even in the SGM and in other places. Next, please. Now here I want to talk about the history or the journey of phasing out dental amalgam use in Tanzania. It was started in 2000, even beyond the Minamata Convention was signed. On the left is Mr. Hemsing Harima from Mauritius. He came in Tanzania to demonstrate to dentists that dental amalgam is not safe, even to the dentists themselves. He traveled all the way from Mauritius to attend a Tanzania Dental Association meeting at the central part of the country at that time, which was really seen as far from Dar es Salaam, because by then Dar es Salaam was the capital. He went where the capital is now, which is Dodoma. So he went to attend that meeting of Dental Association, and he showed to the dentists that dental amalgam is not safe, even to themselves. The next is Dr. Graham Murrow Hall from UK. He's a dentist practicing in the UK, and he came to Tanzania again to participate in another dental association meeting, which is carried out, and the Tanzania Dental Association carries out their annual meeting every year. And for us, really, that was very helpful, because that is the platform we used to reach so many dentists at one time. Next. And at that time, it was the time when there was an East Africa project, which was being advocated that we manage amalgam waste. That means to us engineers, it was like not good practice, because you don't generate waste and then treat it. Usually we prevent waste. So it is like, it was also through this project, that was our entry point to the arena of phasing out dental amalgam in Tanzania. And this project was advocating for use of dental amalgam separators. And I think it's not best practice, because exposures of dental amalgam are not only in the West, they are also in the room as dentists are doing their work. So if you trap dental amalgam within the separator, what happens to the dental amalgam which remains in the room? So again, with the separators, where will you check them when they are full? In Tanzania, even normal household waste, there is no sound infrastructure to manage it, and it would be even more challenging to manage waste from these separators. Next. So whenever we attended meetings or we attended the advocacy sessions, we tried a lot to explain the pros and cons of amalgam separators use. And I think it was understood that use of separators was not enforced. So next. And we noted that the costs of the separators were really high, because one separator was like 1,000 USD. And that is before you treat it. I don't know after treatment how much it will be. So it was really an expensive practice. And as I said earlier, we don't generate waste and then treat it. Next. Yeah, so all what was happening made us think of which strategies to use so that we can achieve the phase out of dental amalgam. So the first thing we did is to form a national task force. National task force containing members from the sectors I've just indicated on the slide. That's from academia, from policymakers, from media, from only, and more importantly, from the consumers. These were represented by the Consumer Association in Tanzania, and I think it was through this Consumer Association, the information was going to consumers easier than if we didn't use them. So with the task force, we collaborated with the government to develop guidelines and regulations and to review the teaching curriculum, to raise consumers' awareness, and encourage consumers to the patients to report to clinic earlier before the caries are big. And we also participate in the implementation of guidelines and regulations. Next. These are some of the advocacy materials we were using. They have some numbers, like what are the advantages of using the mercury-free dental filling materials, and what are the advantages and disadvantages. We had these brochures made and distributed to various target groups. And with this information, the government noted that there are alternatives. Of course, the dentists knew there were alternatives because they were using them. It's not something new. Next, please. So we also organized the strategic meetings. On the right there, it is agenda and consumer association holding a media event so that the information goes to public. And we attended the annual meetings of the Tanzania Dental Association. Through these meetings is where we were sharing information about phase out of dental amalgam. And the meetings, of course, allowed the stakeholders, including us, And the Ministry of Health really was encouraging participation of stakeholders in their meetings. And there were also meetings of the Tanzania dental, the annual meetings of dentists. Every year also the dentists meet, and once they meet, they discuss issues pertaining their work and their progress. And these meetings, through participation in these meetings, it was very, very instrumental in informing, in sharing information with them, in making them change, in making them change their mind. For those who are saying amalgam is still good, and it was also a platform for learning. And we agenda facilitated the Tanzania Consumer Association to participate in these meetings too, so that they give their voice as consumers. Next. It is from that one, after those meetings, after a lot of advocacy, the government decided to develop a guideline. First, it was the guideline which restricted the use of dental amalgam to breastfeeding women, children under 15, and pregnant women. Then came the Mercury regulations, which also restrict, actually these ones banned the use of dental amalgam to children under 15 and pregnant women and breastfeeding women. And after some advocacy and more understanding from all sources of information, the government in 2022 decided to stop completely the use of dental amalgam. And they announced the use of another dental filling material, which is mercury-free. By name, it is St. John. Next. Then, having banned the dental amalgam use in Tanzania, it was thought that we would not be safe, and we also need to do advocacy to other neighboring countries. And we started that with doing the advocacy in the East Africa community member states, and we collaborated with other NGOs in those countries, like the countries in Kenya. We collaborated with Sejat Kenya, and there is KCN Kenya. In Burundi, we have an NGO called PES. In Uganda, we have Probico and NESMAC, and Afrigas in DRC. We started the advocacy to EAC community so that the member states also ban the use of dental amalgam in their countries. Because if we, Tanzania, ban the dental amalgam and those countries don't ban, there is a big risk that amalgam will move from their place to our country. So we think we are not safe until all the regions have phased out amalgam. So they need to harmonize the ban. Next. Now, what do we take away from Tanzania's experience? We appreciate a lot that the government prepared the guidelines and prepared the regulations, because without this, there is nowhere dentists will anchor to carry out their practice, because we believe that they are guided by guidelines they are guided by the law. They cannot just decide to phase out amalgam if there is no regulation or if there is no guideline from the government, because the government is the one which determines what to do in terms of health operations. And we think continued on-job training for dentistry professionals, even after adopting the alternatives to amalgam, it is important that to be done, because we know practices have some changes, and so they need to learn more beyond what was learned in colleges. And we also believe that ability in oral health clinics of affordable and technically sound mercury-free materials is important. Availability of those materials. Materials have to be available in clinics in every corner of the country so that patients don't suffer because of lack of materials. And also in the market, if dentists want to purchase mercury-free materials, then they should find them in the market. And we also think of continued public consumer awareness raising, so that the consumers know that what kind of services are there, and so that they are well informed before they choose what service they want. And by engaging the consumer representatives, that message goes to the consumers easier. And then there is an issue of accessibility of oral health services. In Tanzania, for example, me, I'm in Dar es Salaam, if I want to have oral health services, there are so many clinics around me. I believe also in other regions, the clinics are there. So the oral health services have to be reachable, not at long distances where people cannot access easily. And the last point here is there is really a need for partner support, because I believe for a change like this, an enormous investment is required, which one country may not be prepared to address in a short time unless there is some support from partners. And I would advocate to us all, look for resources, support the dentists from transitioning to mercury-free dentistry. I think that will be very helpful. And I reached out to the National Oral Health Services Director. Unfortunately, he is on leave. Otherwise, if he was not on leave, I wanted him to be presenting with me today so that he described the technical part of it. And I think that is my last slide. Please, next. Yes, that's my last slide. And I thank you very much for your attention. Thanks.
Thank you very much, Dorah, for that particularly insightful presentation. One key takeaway, and I'm hoping that people in the audience are appreciating something, especially the oral health professionals amongst us. The dentistry conversation is not for dentists alone. It's not for oral health professionals alone. And I think that's one thing we can learn about agenda, being able to come into an unfamiliar space to advocate for environmental sustainability and a healthy oral health care practices in their country, although they are primarily driven by non-dentists or non-traditional oral health professionals, if you can call it that. So great work by Agenda. We have our last presentation before we go into just a short panel discussion and then opening up to our Q&A. So Dr. Moodley, please go on ahead.
Good evening, everyone. Thank you, Dr. Baba, for that very warm introduction. And thank you to the two speakers, Dorah and Florian. That was very interesting presentations. So it's great to be here with all of you. Imagine a material that has helped us restore millions of teeth over a century, yet it contains a toxic substance to both human and environment. And now, finally, it has come under global scrutiny. In 2013, the Minamata Convention on Mercury was adopted by more than 140 countries, including South Africa. So my objectives are these, and I'll outline these objectives. By addressing these, I hope to highlight the challenges and opportunities involved in aligning dental practice with international guidelines and national policy goals. So we should base whatever we do on research, because that's what I am passionate about. So the shift away from dental amalgam use is reflected not only in dental practice, but also in academic recommendations and student experiences. A study conducted by Bissoon and Moodley emphasized that dental curriculum should be revised to better align with practice trends and reduce the reliance on amalgam restorations. In line with this, most students primarily use resin composite materials in restorations. Similarly, Kokela and Moodley found that clinicians strongly preferred composite over amalgam in routine daily practice. However, a study done by Moodley et al. Highlighted environmental concerns and noting that 72% of practitioners did not have amalgam traps in their surgery. So there was amalgam waste that was disposed via inadequate methods. Research done in South Africa, dental amalgam is no longer widely used as a restorative material in South Africa. According to Adam and Naidu, 2017, 62% of respondents reported almost never using amalgam, while only a small group of 7% reported using it. Resin-based composite has become the material of choice for restorations of posterior teeth and is commonly also used to repair and replace defective amalgams. This trend was further supported by data from Essa et al. 2023, who reported that resin composites accounted for only 50% of all direct posterior restorations in 2004, rising significantly to 95% in 2019. Students at UKZN cited several reasons for the increased use of composite restorations over dental amalgam restorations in clinical training. They noted that composite is perceived as a safer material and has better aesthetics. It aligns with patient preferences. Composite also allow for minimal cavity preparation. And like Florian mentioned, it is done on one visit patients do not have to come back for follow-up and polishing. The material enables us to use it in a single session. Furthermore, students acknowledged the global phasing down of amalgam due to environmental and health concerns. So, what is our position? Okay, the IADR affirms the use of dental amalgam for the general population without allergies and renal diseases. The IADR also supports the phase down approach, and it states that we should increase prevention strategies to reduce the need for restorative care. The WHO also supports the phase down and even the phase out approach. At the country level, policymakers need to implement measures recommended by the Minamata Convention. At UKZN, we have started the phase down approach in 2014. We stopped using amalgam material on children and in pregnant women in 2014, and this was in line with the other universities in South Africa. Currently, all universities are now in the phase out approach. Our university has stopped training with the use of dental amalgam from this year. For the past 3 years, no dental amalgams were done in the clinic. The WHO encourages integration of oral health supplies into universal health coverage. So incorporating glass ionomers and other dental material into a country's essential medicine list will help align with WHO recommendations for improving access to a mercury-free and a preventive dental care. The latest policy governing mercury use in South Africa is the Regulations for the Management of Mercury 2024, published by the Department of Forestry, Fisheries and Environment. And here it states that we should be compliant. Our practices should be compliant by the 31st of March 2025. We've passed that date. The South African Dental Association has issued a position statement encouraging the phase down and the phase out of dental amalgams as well. So, why should we change? Why should we change to resin-based materials in dentistry? Transitioning away from dental amalgams aligns with the Minamata Convention on Mercury and also supports South Africa's global sustainability commitments. Enhancing the professional image of the private sector will also be a good reason to change. Today's patients are increasingly health conscious, environmentally aware, and they seek aesthetic looks. So moving away from metal-free restorations will be a good choice. Advances in these materials now offer strength, durability, fluoride release, and also minimal intervention approaches and benefits. With increasing regulatory pressures and environmental concerns around mercury use, shifting to mercury-free alternatives not only ensures future compliance, but also reflects ethical and responsible practice. This transition is needed. Also, this transition will present opportunities for us for continuous professional development, skills enhancement in using composites, and will also help in the growth of minimally invasive dentistry. So, there is resistance from private practitioners because of economic motivations. So this is something that we need to challenge and we need to discuss. There is shorter time associated with amalgam restorations, they say. But here again, we should open this to greater conversations. There is perceived complexity with the newer materials. Is that true? This is also an area that we should discuss further. So maybe we should start looking at the lack of continuous professional training out there, and low patient demand is something we should look at. Should we base our practice on a material because we've used it for many years? Should we base our practice because a material is said to be stronger than most other composites that we use? This discussion needs to go on further. So the time has come to address these challenges. We require stronger policy direction. We require more incentives, and education is needed to ensure a cohesive and sustainable shift across both public and private sectors. In 2014, I mentioned before that there was change, and all universities, together with the South African Dental Association, met and adopted the changes advocated in the Minamata Convention. So, why should we engage with this Minamata Convention? We should be concerned about environmental changes. The younger generation, the dentists, and the public are concerned about amalgam, mercury, and the environment. And only if we engage with this, have discussions, we enforce curriculum changes, we base clinical training on what is required out there, we base assessments on what is needed out in practice, and composite and aesthetic restorations is needed out there. Waste management is a huge issue. Is it possible for all of us to change our practices and get equipment to remove amalgam waste? Financially, this is an issue. So we need to discuss this further. Should we make these changes, or should we stop the use of dental amalgam? Curriculum changes at university is something I'm passionate about, and we need to look at. Preclinical training in most universities, amalgam is used in the labs only. When students move into the clinic, they're not using dental amalgams because patients do not want a non-tooth colored restoration. Procurement of amalgams has been reduced significantly in all dental schools. So if we're not using dental amalgams in clinics, patients do not want non-aesthetic restorations, why are we still having this discussion? So we need to reduce exposure to mercury to keep students, us, and patients safe. Universities, dental clinics, private practice should lead by example and should reduce the use of mercury. We need to modernize dental education. Training students with biocompatible, mercury-free materials better prepares them for the current industry practice. Many countries are phasing out amalgams. Dental clinics, universities, and dental practice should align with these global trends. Investing in alternate materials promotes sustainable dentistry and fosters innovation and restorative techniques. The time has come for all stakeholders to transition to mercury-free practice, ensuring a safer, more sustainable, and forward-thinking approach to dentistry. Dental amalgam has served us well, but the future must be mercury-free. Through collaborative efforts, investments in alternative materials, embracing sustainable practice, South Africa can lead the continent in aligning oral health with environmental stewardship. So thank you for your kind attention, and thank you for sharing your precious time with us today. And hopefully we continue with this discussion and lead to a mercury-free South Africa. Thank you.
Thank you. Thank you so much, Dr. Moodley, for that. Really a great presentation to end the three. Now let's jump into the conversation and at the heart of it. Yes, I know that we are running a little bit over the time, but good news for those of you who are registered with the professional councils in South Africa. If you manage to stay until 8:15, you will get your full 2 CPD points. So hang in there, let's enjoy this conversation, and let's co-create environmentally sustainable oral healthcare together. Now, Dr. Moodley, I will jump straight to you. Dorah, you can switch on your video if you can, so that we can have this discussion. We will be picking up some questions from our audience, because we want this as interactive as possible. And I believe we couldn't have put together a better panel actually for this conversation. And I am so happy because of that you are the people who actually decided to participate. One question I have for you then, Dr. Moodley, is how, because I hate to kind of burst the bubble a little bit towards the end, and I think these are the hard conversations we need to have. We do have regulatory mishaps. Florian spoke very well about some inconsistencies in some of our regulations, right? And I mean, you move over, for example, on the one hand, you have the Department of Environment in South Africa giving us those regulations. But you have on the other side, the National Treasury putting out a transversal contract that still has dental amalgam as one of the items you can actually procure as a public sector dental clinic or dental facility. Needless to say, good to hear the work that's happening at that level. And my question then becomes this then, Dr. Moodley. How do you think we can use or leverage these national policies, right? And also the power of professional councils to really overcome this resistance that we are experiencing and actually start driving us towards sustainable change? And I understand the motivations of public oral health are very different from private oral health in this country. And please do tell us what can we do with the regulations that are in place, as imperfect as they are, and what can we do with the power that the national councils offer us?
Okay, I wish I had answers to all these, Dr. Vava, but it just, we have to have conversations. So the universities have had a meeting and a discussion just like this one, and they have decided on a phase out approach as well. Okay, the only problem is the polishing of amalgams and the removal of amalgams. So at that meeting, it was decided that the clinics that service the universities will get these devices to remove amalgam from the water. But the clinics that we think are using amalgam, with patient, like in our clinic, patients don't want the silver filling. So we need to lobby against that. We need to lobby against the use of mercury to keep our water safe. We need to lobby against the use of amalgam. Why should we have a non-aesthetic material on tender to be used? We need to have further discussions. And our mantra should be prevention. So we should work towards the use of the good materials like glass ionomer, getting them on this list that I spoke about. And I think we need to be the product of change. So we need to have further conversations. I hope that answers your question.
And maybe to qualify a little bit and take it a step further, Dr. Moodley, the HPCSA guiding the professions and protecting the public, and we are all registered with this council. Is there a role in the space for the HPCSA to play? Given, of course, that that's the tagline, that's their motto, guiding the professions and protecting the public. How can the HPCSA stay out of this conversation when that is their core mandate? How can it be involved through, of course, the various boards that we are registered with? Now, please, I normally encourage panelists that POHF conversations are liberal conversations.
Yes.
Here, we have room and freedom to collectively dream. We don't necessarily need to, we know historically there have been issues and barriers, but I do imagine that let's collectively imagine how we can go and start using these structures that exist to start driving us towards sustainable oral healthcare practices.
Okay, so if the HPCSA claim to be a custodian of the public, then they ought to be protecting the public. So we need to have conversations with these with the HPCSA in order to change their mindset, because maybe whoever is sitting there is not educated enough about the material. Maybe they have their own agenda, hopefully not, but let's have conversations with them before we make any decisions. I wouldn't mind joining in the conversation.
No, thank you very much for that, Dr. Moodley. Now, Dorah, Ms. Swai, I'm moving over to you. You're probably my favorite person here, and the people who know me, I'm less a dentist and more a community advocate. Now, please tell me and tell us, because I couldn't help but be inspired, of course, by the content of your presentation, highlighting very powerfully the power of civil society, going into an unfamiliar space and actually effecting change at a national level. And I would even argue, actually, a powerful force in East Africa and perhaps a powerful force in the globe. Now, could you share with us a little bit, because there's still more to be done. What kind of collaborations do you think we need to kind of start moving forward with this transition and start gaining significant ground? And perhaps I want to also further add a second question to that, which would be, what really is the role? Yes, it's very clear the role that agenda has played, but there could be people in this webinar who are outside of the dental space, who are outside of the oral health space, and they are also saying, we want to do something. We want to do something. We want to participate in holding our healthcare systems accountable, especially accountable for their responsibility, not only just to people, but to the environment. So what can community level work, organizations do, and what to actually start getting this work or start getting into this kind of advocacy work?
Yeah, thank you, Borela, for your good two questions. The first one is about the collaboration, the kind of collaboration required. really collaboration is key into achieving any results. And with us, we know our dentists, first of all, are very busy in clinics attending patients. And sometimes they won't even get time for advocacy like the one we do with civil societies. So civil societies, if they have capacity and if they have sufficient data, they can convince, they can help shaping the systems so that dentists provide the services that is environmentally sustainable. Because you can imagine telling a dentist to start taking data of this and that in the community, for them it is very difficult. But with civil society, if we are enabled, capacitated in terms of knowledge and skills, we will be able to help them gather data, present data to them, and for them then they can make informed decision on what they are doing. And such kind of collaboration is important in rolling out this kind of work. And the role of civil society is not very different from what I just mentioned. Civil society represents consumers. Many times we stand on behalf of the communities, and whatever we are doing is for the larger community or larger populations of our country. So, because no one community or individual can stand and talk about the problems behind the problems affecting the society. It is through NGOs like ours, we collect data, and we encourage even people to give out information. We also do research to ensure that the services which the people are getting are adequate, or in terms of are adequate, so that the community doesn't suffer because they don't have knowledge. We represent them in many cases, and because of the knowledge we have, then we can become the link between them and the practitioners like dentists. Thanks.
No, thank you very much, Dorah, for that. And now over to you, Florian. Florian, I'll ask you two questions, but I will allow you to answer one first and ask the other one. There's this concept that has become particularly popular in South Africa, especially around the energy transition away from coal towards renewables. So there's this concept called a just transition. Now, what does a just transition look like, both globally, regionally, for dental amalgam? I mean, you had a beautiful slide there that showed us many of the manufacturers of amalgam. I mean, I think the only amalgam I've seen, especially in our setting, has actually been from SDI. I know that our private colleagues probably use it from other suppliers, but I've seen a lot of SDI dental amalgam in our dental clinics. And my question to you is, what has been the conversation and what is the conversation? Because a just transition is, as we move away from this toxic material, we understand that there was a value chain that created jobs, that contributed economically somehow. And how are those protected? And what has been the conversation around a just transition away from dental amalgam? Because manufacturers will stand and say, no. But at least now we are appreciating that ministries of health and environment leadership at country level and at a global level have actually given manufacturers no choice but to actually adhere to phasing out to ceasing manufacturing, to ceasing exports of dental amalgam. But it's just a curious question to you. What does that just transition look like? And what have been the conversations, at least in Europe? And perhaps if you could maybe expand your thinking towards what that could look like within a South African context. And the reason why I mentioned this is that we can appreciate, again, from the same slide, that Africa doesn't really produce any amalgam. We are a net importer, but even within the importing of this material, there is some relative value chain of some sorts, middlemen who have been employed to supply this amalgam to either government clinics or the private dental sector in Africa. So what would it look like in order for us to know that while we are calling for sustainable health, oral healthcare practices, we also demonstrate that we are not blind to other realities that people might raise and say, but what about the jobs of the company that sells of dental amalgam? Knowing, of course, at least in the South African context, that many of these companies don't only just supply dental amalgam, so they will make their money up by bigger orders for their composite, for example. But please do answer the question.
Thank you,
Please
Bulela.
remember to unmute. Yes, thank you. Lovely.
Yes, I was just doing it. Thank you very much. I think it's a tricky question because you can't compare dental amalgam with coal combustion, and you can't compare a product you buy from the industry and privately that is phased out or withdrawn from the market. In this case of dental amalgam, it has been since the introduction of alternatives and the predominantly use of white fillings in private dentistry, it has developed from my point of view, a perverted system, because the use of dental amalgam usually is the material which is reimbursed and used by the public health insurances. So any patient which can't afford white filling is treated with dental amalgam, which on the opposite side had the best benefit for the dentists, that dentists can charge extra for a white filling. So now when we experience this in the opposition from the, well, we call it, it's the dental industry, but it's the dental associations in Europe, especially in Germany, we are talking about this financial interest directly in the UK. We have these discussions in other countries. The question is now, how are you going to manage a transition where dentists got used to have make white fillings for like a special like as an extra a treatment for a special price, which is not covered by the public health insurances. And the question, if you are now asking the public health insurance to reimburse the same amount than dentists make with the white fillings in the private dentistry, for the public health insurance, this is not feasible for most governments, for most health departments of health. So they are now obliged to find and negotiate with the dental associations to what extent a white filling is justified for in terms of workload, in terms of material cost, which usually is quite low. And then to do this, use this or replace dental amalgam in these public health insurances. And I see there a challenge which can only be overcome with political will. And this has been demonstrated in Europe, that the German Dental Association was telling the European Commission that the phase out of dental amalgam with the reimbursement of alternatives in the public health insurance would cost 1 billion euros per year. And this was always their I think, strategy to oppose it. And in the end, the European Commission phased out dental amalgam, made a decision, and the conclusion was that now we have still a two-class filling treatment, but we have alternatives which are like glass ionomers, which are now much more durable than were before. We have Sention or Sention Forte, which is like a material, when talk to dentists, which not needs to have as a retention, which can be let's say glued to the filling, which sticks to the filling, to the tooth, and we can still offer a high-class multi-layer composites for the dentist, so that over the time it should align with this with the business they were used to do it. And in Germany, this transition in the end did not cost almost nothing at all. It was €1 per filling. It was just, I don't know, a 3% increase in the for the public health insurances.
No, thank you for that. I think kind of piggybacking on your comment that this is actually, the transition itself is political. South Africa finds itself at an opportune time. We have the G20 presidency, and within the G20 presidency and the conversations that have been taking place in that space, we've had the opportunity to be part of the C20 Equitable Health for All working group under this G20 presidency of South Africa. And we've been participating in some very interesting conversations, trying to push for some strong recommendations and adoptions as far as healthcare is concerned from a G20 perspective. Now, any one of you can answer this question, but what opportunity do you think then lies in engaging on platforms like the G20? Because what I've learned about advocacy is that you don't have what we call preferential spaces. So, for example, you don't take your message to one space and then say, well, this message is just for this space, and you will not go out of that space and engage other platforms. You want all platforms at all times open to sharing your message. And if our message as a collective then is a message of sustainable oral healthcare practices, which I think we can integrate within a broader conversation about sustainable healthcare practices. We're looking at green health, et cetera, et cetera. What do you think are the opportunities of this presidency for us, and how we can leverage that G20 space, considering it is quite a significant space where we could see perhaps an adoption of additional resolutions to support, for example, the plastic treaty, strengthening resolutions around the Minamata Convention. So what opportunities do you think lie there? Maybe, Florian, you start, and if Dorah, you want to chip in, please chip in. And as well, please don't shy away, Dr. Moodley. And then we will proceed to just taking some questions from the audience before we close.
Well, thank you, Bulela. Well, I think it's a great opportunity. This is the G20 countries. They can really give a push to phase out dental amalgam and for the transition to environmental friendly dentistry. And our organization is not only working on dental amalgam, but we are also engaged in the global framework on chemicals. We have all the other aspects on our radar. so also to reduce the use of single-use plastics. And I believe you can make a well, really a difference with this presidency. I believe it's still underestimated how much mercury is released through dental amalgam, and this needs to be also repeated. That it is like from one single filling, you can with 0.6 gram of mercury, you can pollute or contaminate 100,000 liter drinking waters, and this is what happens, and this is what we need nowadays. If this enters into the environment, and we don't have the capacity to now with the irrigation, with the global warming, wherever, to pollute our environment, our resources, through that's just a material which we have alternatives for, and which can be avoided. And yes, thank you.
No, thank you. Dorah, you look like you wanted to say something there. Please unmute yourself.
Yes, Bulela, like Florian has said, it's a matter of commitment of the G20, but for them to undertake that commitment, they need sufficient information. And if they are serious, and if I understand well the requirements or the goal of the GFC, GFC means sustainable development without harm. And if it is is the case, why should they still retain something that is going to pollute? And what I understand is we, as this generation, we don't need to pollute so that the next generation is burdened with a lot of effort of cleaning the environment and of addressing the problems that we have caused. So I think that fact needs to go to the G20 so that they also make a decision that no need to continue using something that alternatives are already there. And I think that's the best way to do it. Thanks.
No, thank you very much. Dr. Moodley, did you want to add anything there?
Okay, I think we need to have a green earth. We need to have an earth that lasts a long time so our kids and grandkids can be happy and live here safely. So right now, mercury is an issue because it's affecting something that we all need, and that is water. So more than it affects our health, it is affecting our earth. And that is why I think we need to be forceful about this. We need to stop using mercury, not only in dentistry, but in industry and wherever else it's being used. So in order for us for anyone to take our message seriously, we need to look at just not dentistry and mercury in dentistry, but we need to look at mercury in industry, and everyone needs to be in alignment with the Minamata Convention. So health in general, we need to look at how we treat people in medicine, dentistry, and all other parts of medicine and health. We need to look at sustainability in every discipline. So for one example is the gloves we use. Look at the waste we create with the gloves we use. Other stuff that we use in dentistry, we're cutting composites. Who knows what's happening to our water while we cut composites and polish composites? So there's a lot of conversations to be held, not just in dentistry, but in the health sector in general. And I think if we lobby together to work towards a sustainable green earth, a earth that is safe for our grandkids, I think the message will be taken seriously then. So I think we need to group together, have conversations together, and work towards a sustainable health practice.
No, thank you so much, Dr. Moodley, for that. Looking at the time, we only have time for just 2 questions from the audience. Newo Omalebu, any questions in the Q&A? Let's just take one, or anyone that was just jumping at you to pose to our panelists before we conclude.
There are 2 questions in the chat.
All right, so please just pose one. What's the one question that was asked?
So Don Chiwaya says that he's not in support of the use of amalgam, but that what happens when patient experiences, what has been patient experiences in terms of access, considering that from his experience, amalgam fillings are cheaper than white fillings. So I think it's a cost issue of amalgam versus composite in dentistry.
Just a little bit of context for our panelists. I know Don very well. Don is from Malawi. And I think that question is anchored from that perspective. So yes, Florian, you did mention to us the cost conversation that took place, in particular in Germany. Now, the question is asked by Don is, what do we do about the cost implication in low resource settings, pretty much, at this current point in time? So any one of you can take the question from Don. Please don't, Dr. Moodley, Florian, any of you can answer that question.
I will be very, very brief. So what we see with the cost, at least from my perspective, the cost for dental amalgam in all the countries we have been working is far too low. So it is far too low. As I explained before, that there is a gap was created since the introduction of the alternative materials, and no country, no government ever had any interest, especially since the Minamata Convention of Mercury tried to phase down the use of dental, to encourage and give incentives to a dentist to use an amalgam. So they kept this price very low, and we don't see anywhere that this the price of dental amalgam actually reflects the time of work, does not reflect the environmental pollution, and not even the material costs, like compared to the alternatives, which are now having a comparable price. And if so, the government should take incentives to do this, and it needs to also to be communicated to the people that this is, for now, that is not the right pricing they experience, because there's a miscalculation on it. That's what I said before. It has become how a preferred system, because that's the impression people and patients have. But I believe this is not right, and this needs to be worked on.
Dr. Moodley, I saw you,
Yes.
I think, unmute there, yes.
Okay, to add to that conversation, yes, I agree with Florian. We need to lobby, we need to educate, but also you have a patient on the chair, and it starts there. So when you are consulting in a private practice with the patient, you can offer treatment and tell the patient that this is a metal restoration. The problem is it has mercury in it, and mercury is not good for this reason. We have to do this restoration, and it's going to cost you a little more. Give the patient the choice. In government hospitals, why are we being bullied into using this material? We as practitioners need to lobby and fight against the use of this material. If we don't have the proper equipment to separate waste, then we shouldn't be doing it. We should say no. We should start this conversation and this fight against the use of mercury in amalgams and protect our environment. We understand, yes, it's been used for very long. It's proven its strength. Its safety, some people believe it's safe enough to use. We know. But the time has come where the environment is getting hurt by this material. And we should say enough is enough. So have conversations with our patients. It starts there. Then they understand why we're not using it. And maybe then people will be educated and help us in this fight against dental amalgams. So I think we need to educate every patient. And I'm sure if you give patients the opportunity to have a choice, they will choose something that's safer for them and the environment.
I actually think that Ms. Swai would agree with the comment I want to make, and this is a comment responding, or rather enhancing Florian's position. It seems as if there's some malicious intent on pricing related to the use of composites. That in terms of, for example, there's a big gap between manufacturing cost of composites and the actual cost we are charging to the patient, to the people, for actually treating them with these composites. And I think that's a conversation and a place for advocacy to come in to say, what really does it cost the manufacturers to generate and sell these composites versus how much we are being charged by practitioners on the ground? And if it means that we have to take on associations and the private practitioners themselves, then that's what needs to happen. Because ideally, again, we shouldn't be risking population and environmental health for economical or private financial gains of a select few individuals. That should not be happening. Now, as we conclude our discussion, 1 minute each for our panelists to leave us with a takeaway message. I will start with you, Ms. Swai. Please go ahead. 1 minute, just 1 minute, just to close it up for us. One message you want us to not forget after this amazing engagement we've just had. Please unmute.
Thank you. I would insist on the collaboration among the sectors, because environment and health, there is no way you can divide, you can put the line. They are all related. So I would wish increased collaboration from dentists, environmentalists, and even the financial resource mobilizers. There's a very high need for collaboration so that each one can play the role of his in order to ensure that amalgam is no longer in practice. Thanks.
No, thank you. Thank you. Florian, let's pass the mic over to you, and Dr. Moodley will close it off for us.
Yeah, thank you very much, Bulela. I would like to thank you all for participating in this webinar. It shows the interest of you in phasing out dental amalgam and contributing to this discussion. I would especially like to thank Yuka Makino for putting all these studies into and links into the chat, and also for their support. We in phasing out dental amalgam. We met in the Bangkok first global oral health meeting in Bangkok, where the Bangkok Declaration was adopted to phase down or phase out, where feasible, the use of dental amalgam by 2030. And the feasibility was perfectly shown by the example from Tanzania, where you had a regulation with the goal to phase out dental amalgam by 2030 in place in 2020. But when they analyzed and assessed the alternatives, they came to the conclusion, we don't have to wait until 2030. We don't need it. The alternatives are here, they are effective, and they are affordable. So they decided to do the phase out in 2022. And this is the transition was already taking place. And I thank also Ms. Moodley for her presentations and about the role of the universities. And I think that's the takeaway, that together we can achieve the transition. These discussions are very valuable to understand the key challenges and to move forward to overcome these. And I really hope that we will also, with the support from the ministries, from the environment and WHO, we hope that we can also transition or help with the transition in South Africa.
Thank you. Over to you.
Thank you, Dr. Vava, and thank you to Dorah and Florian for this interesting conversation that we had today. The time has come for us to have more discussions like this. I can see some comments regarding amalgams being cheaper, composites being more technique sensitive. Yes, the time has come to stop using amalgams and to increase our knowledge and increase our clinical skills and competency so we can place good composites that last as long as dental amalgams do, but does not hurt the environment. So the time has come for us to lobby and have more discussions with the Department of Health, with the HPCSA, and all other bodies so we can keep our environment safe. Thank you.
No, thank you very much, Dr. Moodley, Ms. Swai, Mr. Schulze. Thank you so much for making time to be with us this evening. It has been a long one. We normally try to keep these very short because our attention spans in the age of TikTok and all of this have become shorter and shorter. But needless to say, I think when we are gathered here for a good purpose, for a good cause, it is all worth it. So a big thanks goes out to our attendees who have shown an interest in understanding what is going on. Indeed, Dr. Moodley, it is important that we keep ourselves abreast of the latest in the developments. And what I've seen often, and this is a comment that Ms. Swai did mention, that what ends up happening is that once you pass college, you actually are done. You would think that you are done and you just get to work without actually keeping yourself abreast of the latest developments. So we hope that we as a profession can actually adopt a culture of continuous professional education, not only for our benefit, but actually for the benefit of the patients that we serve. And I think if we ground the work we do in ethical practice, we will be moving, of course, in the right direction. There's a lot of work, clearly it seems, judging by the presentations, that still needs to be done. I mean, if our 2024 National Oral Health Strategy is telling us we still want to reduce by 40%, we need to be pushing for a complete phase out and an amendment of that strategy or that policy document to actually adopt a complete phase out approach. And this we cannot do alone. We have to do it by working together. Also by bringing along our communities and no longer having the conversation of phasing out mercury in dentistry, or even the conversations around the sustainable healthcare practices as privileged conversations happening in webinars and boardrooms where our communities can't find us. I think it is important that we start going out there, engaging communities, engaging community role players in the form of NGOs, just like Agenda as an example, to actually start bringing them to advancing healthcare practices that are both beneficial for the environment, but also the populations that we serve. So with those words, I want to thank you all, and I want to wish you well, Dr. Moodley, for the Congress over the weekend, and also Florian, for your holiday. I'm not sure what's happening for you, Dorah, but thank you so much, everybody, for really being present tonight. Really, really appreciate it from the Public Oral Health Forum. From us to you, goodbye.